program. If you don't know what those are, I'll talk about those in just a minute. So maybe what hospital you're here and what program you participate in. While a couple other people are joining us, we would love to share wins in the chat. So if you're participating in perinatal substance use care at your hospital, what is going well, right? What is your team seeing as a win over the past couple of months? Maybe it's introducing a validated screening tool at your facility. Maybe it's a particular patient who received excellent care at your facility. Maybe it's just showing up to today's meeting to learn more about plans of safe care. Anything that you want to celebrate as a win, we'd love to hear about it, because we know that you all are out there doing really hard work and trying your best to improve care for patients at your sites. And we will get started in another maybe 30 seconds or so. All right, I will get started and at least show you guys the agenda while we're getting prepped here. We have a few things that we're going to talk about. One is that we have a hospital team that's going to share out some of the wins and what they're working on at their hospital over the past couple of months. So Rose Medical team is here to share with us. We are going to go in depth with plans of safe care, where Colorado is, how a couple of programs are implementing plans of safe care, maybe some tips, lessons learned, things that you guys can take back to your hospital teams. And then we'll briefly cover what are the upcoming events for our programs in the coming year, so that you guys can mark your calendar if they're not already marked. I wanted to take a quick minute, because this is a quarterly call that our team is hosting. We have invited all perinatal substance use programming that we facilitate across the state. And that includes both maternal facing and infant facing programs. So you might see some new faces on here, people that you're not used to seeing in these meetings. And that's because these three programs are all represented today. So in the top teal here, you're going to see the COAIM SUD program. That is the program that does the AIM Patient Safety Bundle for perinatal substance use. It implements universal screening during the hospital birth admission, and then it trains hospital staff on how to do the screening, brief intervention, and referral to treatment protocol, making sure that every patient who is identified with substance use gets the appropriate care before leaving your birthing facility. In the purple, you can see here that we have the Chosen Quick program. This is an infant-facing program that happens in the nursery or NICU that works with hospital staff to train them to respond appropriately to substance-exposed newborns, mainly using the Eat, Sleep, Console protocol for those infants. And then finally, in the yellow, you can see we have the Moms Plus program represented here today too. And Moms Plus really builds upon COAIM SUD, sort of the level 2 programming for hospitals that goes beyond just referral to treatment for patients identified with substance use, but trains the hospital staff on how to actually initiate treatment for substance use. And so helps to fill that gap that patients might experience after being identified and actually being offered and initiating care for substance use disorder. They also help our facilities with naloxone distribution and education. So happy to have all three programs represented today, because I truly think that it's this sort of triad, or this lovely Venn that you see here, that hospitals need the most in order to improve care for our patients. I will get started here and introduce our Rose team. I think who we have here on the call today is Leah May and Linda Wolford. I'm happy for you guys to do your own introductions, and then let me know if you'd like for me to stop sharing, and I'm happy to let you run your own slides. So who wants to start from that team?
Hey Amber, it's Linda. I apologize, my camera isn't working, and I don't believe Leah is able to join today. Not sure. Okay, I talked to her earlier about that. So I am the supervisor on labor and delivery, and I am the leader of our SUD committee here at Rose. And so just a few things that we've been working on the past 3 months. One of the things is that we created a sticker for our charts. So it's a bright yellow sticker so that we can tag our charts for patients that screen positive for SUD. And on that sticker, it has what their score, of course, they're positive, and then also did we enter a case management consult, Was the consult done? Naloxone order, do we have it in? Was the naloxone education done? And did we send the kit home with the patient, or do we have it ready to go home with the patient? So that was one of the things that we've done. Our nurses, just feedback from the sticker was that they would like more of a checklist, like so they could pull a piece of paper more detailed of everything that they should be doing with our patients, so that we're hitting all aspects. So we're going to change that just a little bit and create a checklist that's a little more detailed. Let's see here. And then with that too, we created a resource binder for all of our nurses stations on labor and delivery and postpartum that contains just what the program is about. So we gave it to our NICU nurses as well. And then also it contains just our screening. It has the scripting suggestions. So we have that in there. So the nurses, if they're a little unsure and not very confident about it, they can go back through and look at this before going in and talking to their patient. We have the naloxone take-home information, and then we also have the printout, so they're able to give the information to the patient. So all the information that's on your link as well, so it has the preventing overdose, the different handouts that we can give to these patients. So we're excited about that. And then we also placed our resource list in this binder so that the nurses can grab and give it to the patients too. So I've gotten great feedback on the resource binders, and also the doctors have been looking at it as well. So it's been going pretty good. Let's see here. One other thing. So Leah May, who wasn't able to join, she is our quality manager. She presented Scrubs on Screen just to increase our awareness of perinatal substance use. She presented that to our CNC group. I believe it was last month. So she was able just to talk to them just about what we've been doing on labor and delivery, and then also in the emergency room by increasing our just education on implicit bias, giving out Narcan, and just all the great things that we're working on. Another thing that we've done too in the past few months is just staggering our education a little bit. So we've been showing, so we assigned all of our nurses HealthStream courses, and it has the different videos for our nurses to watch. I believe there was, I can't remember, there was quite a bit of videos. And then there was quizzes at the end. So we just wanted to make sure we were getting that out there a little bit more for our staff. And then also so that we're able to assign this to our new staff as they come on. So that was our main goal too, is we felt like we were missing our new staff after we did all the other education. So that's our goal too, moving forward, just to make sure that they get assigned to that too. Some of the feedback that I got from that HealthStream, some of the videos you can just click through, and you know, and then so I feel like it may not have been totally watched by some of our nurses, but the nurses that did watch these videos, I got some great feedback from the videos, and they loved it. So I think moving forward, one of my questions was to, you know, see if I can get help from Moms Plus and CPCQC, if we can do another live course. We were hoping to make this mandatory for our staff for the all of women, so it'd be our NICU team, postpartum, and L&D. And we were hoping to do maybe a 30-minute sessions, 2 to 4 times next month or in May, whatever the availability is. But I think that would make more of an impact on our staff. And so I think that's what they were hoping for too. Some of them do have more questions just on scripting, and I think that would be beneficial for our staff. Other than that, so we are also working on going live with our order sets for comfort and withdrawal. We were asked to hold off on this just a little bit by our OB chair, because she wants to make sure that we have a lot of our other processes in place before we do the education with our OB providers. So as far as our policy for tox screen as well. So we're working on that. So hopefully once that's done, then we'll be able to do more education with our providers have a little more buy-in as far as for like the naloxone patients going home with naloxone. I do believe we have increased the kits that we've been giving out in the past couple of months. So I think the education and just constant reminders have helped as well. And our committee, we've decided to create a newsletter so that we can send updates to our staff every 2 weeks or so after we meet at our meeting. So that's when we're meeting too, is every 2 weeks. And then we're also trying to do some case reviews as well. And that's it. And then we have our quarterly meeting scheduled with CPCQC and Moms Plus on the 21st. Do you have any questions?
That's so much. You guys are working on so much all at once. It's so fun to hear how you guys are like pacing your work. We all have a love-hate relationship with HealthStream, right?
Yes.
And just looking through modules, we love the idea of making some of those trainings live and working together on it. Guys, if you want any resources from Linda, reach out in the chat. So if you're interested in her checklist, or maybe how Rose decided to sequence their nursing education for perinatal substance use, anything that she spoke about, please reach out in the chat or we'll put you in contact afterwards. Sharing resources is the best thing about a learning collaborative, right? We shouldn't be recreating the wheel. So if Rose has interesting things that you guys could benefit from, we'd be happy to facilitate that. Linda, thank you so much for presenting and for the hard work that your team is putting in. If you guys don't know what she means by scrubs on screen, I'm going to put it in the chat because it was a fascinating program that Rose does for their providers, and I'll give a little more context for it in the chat. So thanks, Linda. Let's move on. We have Shannon Bryan, who works for the Division of Child Welfare at the Colorado Department of Human Services, here to share more information with us about the mysterious plans of safe care that we keep talking about. We hope to demystify it a little bit here for you. Shannon, I will turn it over for you. I'm happy to stop sharing. You can use your own slides. And if you want to do a more in-depth introduction of yourself, take it away.
Hi, everybody. So actually, I am going to sort of pivot and hand it over to Lauren. Lauren and I were kind of coordinating a bit on this, and she's really going to focus on like plans of safe care implementation and what that looks like in the clinical setting. And then there'll be a part at the end that's going to talk a little bit more about like, so what is the intersection between this and CPS and the CPS system? So I am going to do a quick little pivot, but I'll be rejoining you all in just a bit. Lauren?
Yeah, thanks, Shannon. So I'm going to share my screen, if that's okay, Amber and CPCQC folks. Let's see.
And Lauren,
yes.
I missed it. Please do an introduction for yourself.
Oh, of course. Let me get to this. Okay. So thank you everyone for sharing your lunch break with us. My name is Lauren Bruns. I am a general pediatrician by training and work exclusively in the newborn nursery setting via Children's and the university. I'm generally at the university nursery, but do staff some of the other nurseries in the Denver metro area. I am on the chosen steering committee, leading the plans of safe care efforts. And then I also do work with perinatal navigation services with chosen and the maternal opioid misuse model at Denver Health. So I'm going to go just briefly into the background of plans of safe care and then get into kind of some best practice recommendations in terms of thinking about implementation. And then we will get into how this kind of ties back with CPS. Is this not, sorry, everybody. Okay. So as to kind of lay the groundwork, I wanted to give you guys a background on where plans of safe care even came from. So in 1974, the federal government passed the Child Abuse Prevention and Treatment Act, which is abbreviated CAPTA. So when you guys hear CAPTA, that's what that's referring to. And that did a few things amongst those established definitions regarding child abuse and neglect kind of at a national level. Identify the role of the federal government in terms of research evaluation, data collection as it pertains to child abuse and neglect, and then assigned federal funding and guidance to states to support prevention, assessment, investigation, prosecution, and treatment, all related to child abuse and neglect. And so actually, plans of safe care was first mentioned over 20 years ago in 2003 in the Keeping Children and Families Safe Act. So at that time, the verbiage was the development of a plan of safe care for the infant born and identified as being affected by illegal substance abuse or withdrawal symptoms, and stated that healthcare providers involved in the delivery or care of such infants notify CPS of the occurrence of that condition, but that did not constitute as a definition of abuse and neglect. So basically, this plan of safe care was first mentioned, but only for infants impacted by illegal substance abuse or evidence of withdrawal. And then also this requirement that in some fashion, healthcare providers notify Child Protective Services of the existence of that child, but that did not define abuse or neglect. We got into a little bit more details and nitty-gritties of plans of safe care in 2016, but between that in 2010, CAPTA reauthorization added FASD diagnosis for plans of safe care development. So basically then infants impacted by illegal substance use or withdrawal symptoms and with an FASD diagnosis had to have a plan of safe care. In 2016, CARA, which is the Comprehensive Addiction and Recovery Act that was signed by former President Obama, kind of in response to the opioid epidemic, modified CAPTA, stating that plan of safe care address both the needs of the infant and the needs of the affected family or caregiver, and basically then encompassed kind of all in utero substance exposure and FASD. And at that point, again, it says following the release from the healthcare providers, that plan of safe care be in place. There really was not any further direction in CARA at that point. So just to kind of like summarize that, basically a plan of safe care does not mean that a child is abused or neglected. All infants with prenatal substance exposure should receive a plan of safe care. Does not, again, have really anything to do with abuse or neglect. If you are in utero exposed, you should receive a plan of safe care, period. And that this plan should be developed with input from the parents or caregivers, and then any collaborating professional partners who are involved in that family's care. And that, of course, includes the healthcare workers and community agencies. So in terms of what that means in Colorado, I kind of wanted to back up and remind folks about how we in the state of Colorado define child abuse and neglect. So prior to 2020, you can see that child abuse and neglect as it pertains to in utero substance exposure was really kind of hinged on biologic testing. So abuse or neglect is defined as any case in which a child tests positive at birth for either a Schedule 1 or Schedule 2 controlled substance. So kind of does not matter how that impacts the baby. If there is a positive test, that equals abuse and neglect. So in 2020, Senate Bill 20028 redefined abuse and neglect as it pertains to in utero substance exposure, and said that abuse or neglect is defined as an infant being born affected by alcohol or substance exposure, except when taken as prescribed or recommended, and that child's health or welfare is then threatened by that substance use. And so you can go in further to define what does affected by and what does threatened by mean. And so in child protection definitions, affected by is when it impacts the child's physical, developmental, and or behavioral response. And then threatened by is when the medical, physical, and or developmental needs of the newborn child is likely to be inadequately or unlikely to be met by the parents or caregivers. And so again, just kind of rephrasing the idea of abuse or neglect equals positive biologic test of baby to how does that in utero exposure impact that child and the ability of that child's needs to be met by the caregiver. And then another reminder that back in 2019, a Colorado law was passed that makes any history pertaining to substance use during pregnancy not permissible into evidence in a criminal proceeding up to a year postpartum. So again, providing protection for pregnant people who are seeking care or treatment for substance use disorder. So I think kind of with those things in mind, wanting to move forward to how does that all shake out for plans of safe care in Colorado? So we in the state of Colorado have said that a plan of safe care should be a collaborative plan designed to ensure the safety and well-being of an infant with prenatal substance exposure following his or her release from the care of a healthcare provider by addressing the health and substance use treatments of the infant and also the affected family or caregiver. So I kind of want to pause and reflect on the fact that nowhere in this definition is there any allusion to child protective services. So just a reminder that, again, any infant with in utero substance exposure deserves a plan of safe care, and that is separate to child welfare. And that's part of the reason that that we wanted to put the CPS piece at the end of this presentation to ground everyone in the fact that infant with in utero substance exposure equals plan of safe care, and then we can think about DHS or CPS. I don't know why. So best practice for plans of safe care, ideally, this would be established during pregnancy by a multidisciplinary team and that pregnant person prior to the delivery of a child, prior to any potential need for child welfare involvement. And ideally, this is a living document that caregiver or family can kind of own and use to advocate for themselves and kind of further their care. With the idea being that by supporting pregnant people and their families with resources and recovery needs prior to delivery, we can set that family up for success and prevent or kind of like preclude any need for child protective services. Again, separating plans of safe care for any infant and family impacted by substance use disorder from that child welfare involvement. So I think kind of before we move into what does this look like in terms of implementation and actual nitty-gritty stuff, wanting to ground ourselves in the fact that a positive toxicology test no longer defines abuse and neglect, and therefore no longer requires an automatic call to child welfare. And Shannon will get into a little bit more of that here at the end. And that really we want to elevate the impact to the child as the main consideration, and kind of further moving towards a 2-generational approach to keep parents and children together during treatment for substance use disorder and recovery. And again, by moving upstream, just kind of increasing access to resources and support in hopes of not even needing to interface with child welfare. Okay, so before I kind of talk into what does that look like for hospital and healthcare-based professionals, are there any questions? I've not been monitoring the chat, so for Amber or CBCQC folks. We feel like we can forge ahead. I also can't see many faces. Okay, okay, we're forging ahead. Okay, so kind of reflecting back on what benefits do we get from all working together. And Courtney Everson, who is a PhD at the Colorado lab out of DU, I think kind of put it best when she said that really we should think about plans of safe care, moving that beyond a mechanism for child welfare compliance to be leveraged as a mechanism for state innovation around coordinated service delivery. Together, we can cultivate a culture of collaborative responsibility for ensuring Colorado families have every opportunity to thrive. So grounding ourselves in the fact that plans of safe care are more than just a means for us as a state of Colorado to stay in compliance with CAPTA requirements and to move towards just taking better care of all of our families. So as kind of as it exists right now, the DHS is kind of charged with creating a plan of safe care if there is not one that is currently in existence for infants with in utero substance exposure who have been screened in. And so what I want to kind of underline is the fact that if we rely on Child Protective Services to be the creators of and developers of the plans of safe care, we are missing a whole cohort of infants and families impacted by substance use disorder, not to even speak of the fact that we have missed an entire prenatal course and opportunity kind of for prevention. So if you take our population of substance exposed newborns, there's only going to be a small amount of those for whom there is a concern for abuse or neglect, and then only the subset of those who are screened in by DHS will then receive a DHS plan of safe care if there has not been one already created. So again, wanting to decouple this from DHS and say that every infant and family impacted by substance use disorder could benefit from this approach to their care. So I want to recognize, like, I myself am a healthcare provider. I take care of babies in the nursery. I've taken care of many families impacted by substance use disorder. I myself kind of embedded a plan of safe care within Epic at Denver Health. And I, as a champion of this work, found it to be, it's a lot. And so I just kind of want to recognize that we all want to do the best we can. If we are sitting in this virtual room, that we're all here and want to do the best we can to support families and patients impacted by substance use disorder, and providing trauma-informed, thorough, complete, collaborative care is resource and time intensive. Time is a limited resource and change is really hard. So I just want to be fully transparent in that, like, I was championing this work at Denver Health, and it was a lot, and it's a lot to do. But it is good care for our families. So in thinking about opportunities to implement plans of safe care, I like to think about it in a few different time points. At Denver Health, I started by creating a plan of safe care during the birth hospitalization. So if a pregnant person with a history of substance use disorder came in and had a baby, we, as the pediatric team in the newborn nursery, put a plan of safe care into that family's medical record and in that infant's medical record. And as will come as no surprise to anyone, as we were thinking about what are the needs of this family, what are the needs of this infant, and we are doing that in a sometimes like 5-day hospitalization, we all kind of realized, like, wow, we have missed a lot. There have been a lot of missed opportunities. Why are we scrambling at the birth hospitalization to get these folks kind of plugged into resources? So that was, out of that was born the idea of starting to engage with families prenatally. And Dr. Kaylin Klee at Denver Health was kind of my champion in piloting that. And she unfortunately wasn't able to be here today, but I have a couple kind of like little tidbits from her that I will speak to. So this is sort of how we have targeted this, and then post-discharge, finding folks who will continue to champion these efforts. I think in terms of identifying stakeholders to help get this off the ground during the birth hospitalization, it was really important to make sure that I had buy-in from the people taking care of the infant, so the NICU providers and the nursery providers. It was important that I had buy-in and support from our L&D or mom baby social worker care manager, because they were doing the bulk of the heavy lifting when it came to doing some of our resource inventory and making those referrals. And then of course having clear, transparent communication with our families who were helping create these plans of safe care together, and identifying folks on the labor and delivery side, or people taking care of our pregnant patients, so family medicine, OBs, nurse midwives, to also understand that we were trying to do this during the birth hospitalization. As we moved this forward prenatally, again, always having family buy-in, support, engagement, always being at the top of that list. But then identifying at Denver Health, I was able to identify Dr. Klee and her clinic, and she was kind of the champion in terms of prenatal care. And then some of my colleagues in the substance use disorder behavioral health space. And moving towards post-discharge, as these infants were discharged from the hospital, I was making sure I was engaging with the outpatient pediatricians to see, from an infant standpoint, how are you guys using this? Is this helpful? What is not helpful? What do you need? And then our clinic-based social workers to continue to kind of follow up on that. So in terms of what prenatal engagement can look like, so as of right now, Shannon and I are in the process of developing a state template for plans of safe care. Many states have those. We do not have one yet. And so Shannon and I are developing this. Because we did not have one developed, I just kind of made one up in collaboration with Dr. Klee, some of our other folks who I had stakeholders with who provided feedback with folks with lived experience. I had folks who interfaced with people who have experience with incarceration and substance use disorder. So I had a lot of folks kind of oversee what a prenatal plan of safe care would look like, and then transferred all of that into Epic, which I will show you in just a second. One kind of thing that I ran into in thinking about implementing this was, do I have this live in Epic where it's not really family owned, or do we do this in paper, which is kind of the best kind of poor man's way to trial this? We ultimately decided to have it start in Epic so that we as a healthcare team could kind of work out kinks before then making it a paper copy for families. Depending on kind of what your institution's capacity is and EMR situation looks like, I think there are pros and cons to both of those. The kind of family-owned and initiated paper copy of the plan of safe care is nice in that I think that if it is up to the family to like fill that out and talk to their provider about it, it really leaves space for advocacy and reflection. Of course, the downsides are everything that comes with the fact that that is paper. So confidentiality issues, the fact that like you can forget paper, or that gets lost and things like that. The EMR-based prenatal plan of safe care, which is what ultimately Dr. Klee helped pilot, was nice in that it was very easily accessible to all healthcare providers taking care of that family. And then of course was easily updated at visits because it was not on paper, and of course is secure. Downside being that for that to be part of the workflow of the prenatal care provider, it is time intensive and it's a new kind of just a new thing for that workflow. And so you know, there are pros and cons to everything. I did put a link into here. This is something that Moms Plus put together in terms of support around billing codes that could be used if prenatal care providers are using prenatal care time to develop a plan of safe care. As of right now, there is no Medicaid billable code for plan of safe care, which I am advocating for. So again, Dr. Klee was not able to be here, but I did want to share her experience in piloting this with her patient panel. And she said that the patients seem to appreciate the extra time and effort to document all the good things they are doing to invest in their health and recovery. And the most positive feedback has come from hospital-based social workers who have said that having the plan of safe care in the patient's chart has helped prevent unnecessary CPS reporting, as well as created a more positive rapport with patients. So this is, as Dr. Klee pointed out, this is extra time and effort, but at the end of the day, this is a great opportunity for families to advocate for all of the things they are doing in their recovery journey. And if this can serve as a way for them to advocate for themselves, and give their healthcare team or their entire care team a way to advocate for them, and prevent any sort of unnecessary CPS involvement, I think that we can all agree that that is like that is a win. This is a like incredibly kind of daunting thing to take on. And again, I just want to like be transparent and acknowledge that like I feel very passionate about this work and champion this work at Denver Health, and it's a lot and it's a big lift. so the Support Colorado Plans of Safe Care work group put together some best practice recommendations for plans of safe care during the birth hospitalization, because that, to us, when we kind of reviewed this work a couple of years ago, felt like the easiest audience to sort of target at first, with the assumption that most every pregnant person will encounter a hospital to deliver their child. And if we can develop some best practice recommendations just for that birth hospitalization, then we can move upstream and think about how does this look prenatally. So the idea is this is a living document that is shared with anyone who is hospital-based. And there is also a section that is geared toward child welfare representatives. It's currently being reviewed by DCW to kind of get their stamp approval. But I think it's also helpful that there's transparency on both sides. So a hospital-based social worker could pull up this document and see exactly what child welfare workers are seeing when they encounter a family impacted by substance use disorder. And on the flip side, a DHS worker can pull up this document and see, okay, what are our healthcare providers doing? So this is more geared toward folks, or for the healthcare providers who are caring for the infant. And just a reminder to think about defining physiologic readiness of that infant for discharge. And so it is not a hospital-based policy. It does not speak to medication. If that infant should use pharmacotherapy, it is just a kind of general things to think about as you anticipate getting close to that infant's discharge. And then we wanted to kind of have a skeleton of possible referrals and needs of families that could be met during that birth hospitalization, such that the pediatric team, the team caring for that delivering person or that birthing person, and the social workers or care managers can all have these things in mind. These are certainly not exhaustive, but just kind of an idea of what families can, what providers can think of when they are helping prep a family for discharge. And then some key points when thinking about moving towards that discharge planning is identifying who's going to be taking care of the baby, and can they take care of the baby? Are they meeting those baby's needs? And there is also this is just little screenshots. There are also kind of a laundry list of handoff to PCP and things like that, which I'll get into. So when I step back and think about how did I kind of get this off the ground at Denver Health, it was a lot of education, a lot of cooperation, and a lot of collaboration. And I mean, that's sort of like the secret sauce, I feel like, to most anything in terms of trying to move towards change. We worked to sort of standardize some of the conversations we had with families at the time of admission of that infant who is impacted by substance use disorder. So making sure that whoever is seeing that family is discussing ESC, feeding goals, indications for escalations of care. What does it mean to be ready to go home from an infant standpoint? And then if the plan of safe care has not been addressed prenatally, introducing that idea. Early involvement of your unit social worker or care manager to do kind of an assessment of current needs, follow up on referrals or resources that have been previously addressed, and then initiate any new referrals that are needed. And again, I will kind of show you that laundry list to serve as a guide, and then making sure that there is the person developing that plan of safe care for the infant is collaborating with the birthing person's provider team. So making sure there is access to MOUD. Has there been provision of naloxone? Are we making sure we're doing everything we can to facilitate rooming in if that is something that is desired and appropriate for the family? Advocating, I have found that occasionally it is the pediatric team that really has to go in and advocate for that family to receive whatever care, be it behavioral health, mental health, or addiction medicine support. So really just kind of serving as an advocate for that whole family. And because I cannot belabor this point enough, involvement with DHS and CPS is not mandatory for infants with immuno substance exposure. It is only if there is a concern for abuse or neglect. I want to do a time check. Amber, it's 12:42. Are we good? I have your face is in my window. Are we okay?
Yeah, I think we're
Lauren?
good. For those of you who have questions in the chat, though, we'll probably respond to them in the chat as we go.
And Lauren, I might need 10 minutes. So.
Okay, perfect. Yeah, that's perfect. So I will not get into all of the nitty gritties of an EMR-based birth hospitalization plan of safe care versus a paper copy, because it's not terribly dissimilar to what I had mentioned earlier. At Denver Health, we use an Epic-based plan of safe care that lives in the infant's problem list. We put it under the problem care plan discussed with patient, and I made sure that our social workers and care managers had access to the problem list and could update that. And so that's how we did it. I think paper-based plans of safe care, again, have all the pros and cons that I mentioned previously. To again remind everybody, Shannon and I are working on finishing up our standardized template for the state to use. But those are kind of easily transferable to Epic, which is basically what I have done. And so if that is a way to make sure that it is completed during a birth hospitalization, then you can just print it out and give it to the family. So I think there are pros and cons to all of that. These are the templates that I had used. So this is the template that I put in Epic, and then just kind of transferred that to paper. If there were, I had folks reach out to me that did not have Epic or didn't want to put it in Epic and just needed like a paper copy. Again, Shannon and I are working on something that will actually have like the state's seal of approval. This is what I was piloting with a small cohort at Denver Health and now at the university. Reminding ourselves to be very deliberate when we are thinking about coordinating discharge, and how important communication is in taking care of a family's communication with the team who will be taking care of them, outpatient communication with any specialty referrals, and again, only DHS if that is applicable. This is a flow sheet that is just kind of a quick and easy reminder of the steps in thinking about birth hospitalization care of these families that is available on the Support Colorado website, as well as our best practice recommendations. And now I will kick it over to Shannon when we think about, okay, but what does CPS have anything to do with any of this?
Thanks, Lauren. And I am actually going to use my own slides. So I'm going to start sharing my screen if you can stop. They're the ones that we used the other time. And so I know that we are throwing a lot of information at everyone pretty quickly. Like Lauren said, we really did want to focus on how plans of safe care look in the healthcare space, which is why the majority of the presentation has been on that. And we'll just talk a little bit about this intersection between the healthcare providers and child welfare. If more in-depth support is necessary for your team, you can reach out to Lauren or myself, and we can go ahead and provide some more in-depth information. And I believe all the links for the resources are being shared. So we'll make sure everyone has all the information necessary. Can folks see my slides? I think so. Okay. So a little bit about, all right, so I do just want folks to know that when we're talking about this population, referrals for infants who have been prenatally exposed actually only represent about less than 2% of the child welfare reports we receive. I do think it's really important for everyone to know that 36% of these caregivers who are being identified had child welfare involvement as a child. So really thinking about that multi-generational kind of the impact of trauma and system involvement and how we approach these families and wrap around them. And then I do also kind of the bottom stats just demonstrate why there is so much overlap and collaboration necessary between our two systems. with 88% of the referrals of that 2% coming from the medical system, and 63% are coming from our hospital social workers. So yeah, what happens after a referral is made to child welfare and it's determined that further actually, let's do this one. Okay, so this is just a simple flow chart. It's available online of what happens like when we receive a referral at child welfare. So someone calls, they get a bunch of, they provide a lot of information to hotline. That information is then reviewed by a team of caseworkers to determine if abuse or neglect may have occurred. We really use those definitions of abuse and neglect in our volume 7 that Lauren shared earlier. It's on a piece of paper, and our caseworkers read that piece of paper to compare what's in the referral to what is the definition of abuse and neglect to determine if more information is necessary and we need to come out and get more information, how quickly we should respond, as well as if we should engage in an assessment. So there's a lot that goes into that. And when we're also thinking about response time, again, it's very, the response times that we have are really are dictated in volume 7 again, and specific to the reported information that we receive. So it might be 8 hours, 3 days, 5 days, and that's really going to depend on what we receive in our referrals and if it, what level of concern there is about immediate risk and safety concerns. So once you call, you may be receiving a lot of these questions. We need to hear off the bat that this is about a substance-exposed newborn. In our statute, it still says that, so we know that's not person-friendly language, but that's the language that is in our statute. That's the language that's in our system. Our hotline staff should be asking these 5 questions. They're not always. We still need to do a lot of training on our child welfare side of things as well, but there's these 5 questions. Was the infant born substance exposed? If yes, how do you know? They do still ask about drug screens, but it's not required unless the court has become involved already. If a judge requires it, that's different than a caseworker requiring it, so I do just want to make that specification. And then is the infant experiencing withdrawal symptoms? These questions, they're pretty high level. But this is, again, the information that folks read to determine if further assessment is necessary. If further assessment is necessary, there are these questions that start popping up. And so we're really asking for healthcare providers to work with our child welfare staff to answer some of these questions, because we're not experts in these, in medical, in anything to do really with the medical state of a family, of an infant. And we also aren't there with eyes on the family to understand what the interaction is between the caregiver and the infant in, engaging in supportive plans. So they really dive into these questions a little bit more. They do ask for a plan of safe care if one has been provided, to then receive a copy of that plan if the birthing individual is okay with that. The plan of safe care is also really important because it has one section that's for infants and one section that's for the birthing individual. If it becomes necessary for the infant to enter foster care, kinship care, or some other care that's not with the birth parent, that infant piece, we're hoping to provide to the foster care, the kinship care, to those providers, so that they also are on the same page in terms of how to meet the needs of this infant. So both pieces are really important for engaging with our staff if we become involved. I do want to just show that since we changed, I want to share a little bit of data, just so people kind of get an idea of the landscape that we're working in. Since we had the change in definition of abuse and neglect, that really changed, right? How many of these referrals we're screening in versus screening out. So that's what you see at that top graphic. And the number of referrals for substance exposure of a newborn that are being screened in has been declining, and now better matches kind of our overall reports for child welfare for the variety of reasons that we may receive a referral. So you see it's been consistently going down over the last few years since that definition change in abuse and neglect. What I do want to point out about that, right, like if that number continues to go down, we still know that there's infants who are being born with that prenatal substance exposure, and those infants and their families still need support, right? But it's not necessarily going to be support that's received through child welfare, which is why plans of safe care, again, are so important to wrap around these families. And I do want to speak also a little bit too, and this is what the bottom graphic shows, there's this concern, right? Well, if we keep screening out these infants, are they going to come back into our system as a family for a more serious, more egregious concern? Like, if we screen them out initially, are they coming back for a near fatal incident or something more scary? And for the most part, our data doesn't support that, which I think is, again, something good to know. So we see that out of the number of so the percent of new screened in referrals from previously screened out families was about 33%. And over 90% of those were still identified as minor severity. So even when they did come back in, so even if 33% of those screened out referrals came back in at a later date, they were still at minor severity. So not serious, not egregious, not near fatal. So I do just want to share that information, that it is an opportunity to still wrap around families and keep them safe with a plan of safe care, and that the percentage in terms of serious safety concerns is relatively low. So this is demonstrating the number of plans of safe care that are being completed year over year. You can actually see there's been a decline. And this is concerning, right? So part of this is that we're only capturing the numbers that are being completed and reported to child welfare. We have no idea how many are being completed across the rest of the state because we don't have a tracking system. I'm going to talk a little bit about that in a second. But I do just want to say, like, if we know that there's these many infants that are being identified, we really want to make sure that they're receiving a plan of safe care to, one, meet the treatment needs of the infant and to really enhance and support the treatment needs of the caregiver to support that family over time. So there are a lot of opportunities for collaboration. I think Lauren has spoken to this, but it's really important to understand what your own hospital policies are regarding reporting substance exposed newborns to child welfare. We as a state entity cannot tell your hospitals what your policy is. We can only say how we will respond to your reports and to your referrals. The other thing I do want to say, though, and make really clear, is that as a state, we have like our state laws, which are volume 7, and our rules. Then we have, as a state, what we say is best practice. However, there is variance, and I think you all know this, there's variation between counties. And that's also right, we see variation between hospitals because we all have to meet certain standards and meet what's written in the law, but how we interpret and implement best practice is really up to counties specifically, as long as they're within the bounds of the law. So I do want to be clear about that. I know there's sometimes folks are like, well, you as a state can say this is best practice, you must do this. It really depends. If they're not breaking the law, then we can provide more education, we can provide encouragement and support, but we can't necessarily tell them to change what they're doing unless it's not within the bounds of our volume 7. So yeah, these are just some other opportunities. I will also say that we are encouraging healthcare providers, because of that county variation, we're encouraging hospital systems to meet with their county child welfare departments and to set up essentially like these collaborative learning kind of team meetings where folks sit down and say, hey, we had this case of a substance exposed newborn. Here's what happened. This went well, this didn't go well. Here's how we could improve our practice. Help us better understand what child welfare you need as a system. This is what we need as healthcare providers. So we're really encouraging that folks do that on a community-based level. And I am happy to support with that. I have been helping a few communities, but just something to think about. And then some changes that are on the horizon, because I do want to make sure we leave a few minutes for questions. We are, as Lauren said, we're completing that standardized plan of safe care template that will be similar across the state, that is also inclusive of child welfare providers. We're looking to increase support for prenatal plans of safe care. And then there's this piece about referral versus notification. So Lauren mentioned this, right? Our federal law says that yes, healthcare providers must notify child welfare of a substance exposed newborn. However, that notification should not require that it be identified as abuse or neglect unless it actually meets the definition of abuse or neglect, right? We don't want to widen the net. In Colorado, that's a little difficult because we don't have two separate systems. We don't have two different ways to make a referral versus a notification. Other states do. It's something we're looking at doing as a state, so it might be something that will change in the future. This is the referral versus notification language. That's the federal language. Again, you guys will get these slides because I do want to leave time for questions, but just to say that federally, we really need to have separate pathways. One for notification, like, yep, there was substance exposure of a newborn. Maybe they were exposed to marijuana. However, we do not have concerns about their safety. We don't have concerns that the family can't meet these needs of the infant. So we really are just identifying that, yes, this occurred and they received a plan of safe care. Versus, right, we have a family who is using substances. They don't seem to be able to meet the medical needs of this fragile child, and they continue. And there's a whole series of questions we ask our caseworkers to consider as well. So there's two different levels, right? And we're trying to identify how we can create notification versus referral. That's something as a state that's going to be happening, and I just want you all to be aware of. Nothing for you really to do right now other than to know that this is happening. All right, I'm going to stop sharing my slides if I can for a couple questions. Sorry that, as you guys can tell, there's a lot of information that could be shared. How do I stop sharing? I don't know how to stop sharing.
You did.
But
You
go
stopped
ahead.
sharing.
I did stop sharing?
Friends, there were questions in the chat. Many of them did get answers, but if you had a question in the chat you feel like didn't get answered, feel free to either put it back in or come off mic. Otherwise, the floor is open for these last minute or two to ask questions.
I think there was one question that stated, is this CPS algorithm standardized across all the counties in the state? That doesn't have an answer yet.
What do you mean by the algorithm?
I think
Sorry.
we mean the decision tree.
Oh, yeah. So that decision tree is standard across the state. So a referral is received by hotline staff. They ask those questions in addition to some other questions, because, right, maybe substance exposure isn't the only concern. So there's some additional questions that may be asked. That information is reviewed, and then more determination is made from there. I will say, you know, if something is identified as like incredibly emergent, like there's a possibility of a fatality right this moment, then it may be reviewed by like a caseworker supervisor at that point who has more of the experience as opposed to a full team. But for the most part, yeah, that's standard across the state.
And then we also got a question, is there any evidence or resources that can reflect the extent to which Plans to Save Care is working to become culturally responsive as well?
I think that's a really great question. So as in Colorado, no. Nationally, yes. So there's a lot of work being done right now to really look at how Plans of Safe Care can be adapted and supportive, especially for our Native American and Alaska Native populations in particular. So there is nationally, there is evidence. We have not as a state reached a level where we have started to build evidence that I know of.
Shannon, this is Rachel Duncan. Hey, great to see you. I get a lot of questions from hospitals about that notification. And I just don't know how to better explain it, because I think a lot of hospitals have this concept that they're like required to do that notification based on you know, an outside entity asking them to do that, and like what happens with that. Is that actually a report? Could you provide a little bit more clarity on the current status of that? And I know you said that that could change maybe in a better way.
Yeah, so I do think, so two things. One is I really encourage, again, because there is county variance at the moment, to talk with your local teams and to see what they are doing and what they are wanting in terms of notification versus referral. The other piece that I'm kind of hearing, Rachel, from your question is around what's known as red letters. And that practice is a little bit different. So when a county, I think some counties are sending out letters preemptively to hospitals saying that you must let us know if this individual gives birth in your facility, and because there are these substances, and sometimes those letters even go further and ask for you to preemptively complete a toxicology test. What I will say specific to that is that there's a lot of variance across counties. Not all counties do that. And we as a state have actually reached out to our attorneys to get more guidance. And we are in the process of drafting guidance for all of our counties related to that practice, because it is not in alignment with what, right, it conflicts with our change in definition of abuse and neglect. So it's sending a lot of mixed messages, and it's really confusing. And so we are in the process of writing guidance to make it more clear. I'm not sure if that will lead to any statutory or legal changes, but I think it's a great first step to say, hey, counties, this is the guidance. And I'm sorry, I can't speak more openly about it yet because we're in the process of creating it. And we literally just got our attorney guidance like a week ago. But there's a lot moving there as well. And so, yeah, some counties are asking for you to respond immediately. What I would say is, we're really not supposed to do a notification process that automatically results in a referral for abuse and neglect. And currently, that is how our system is set up. And so if you are receiving pushback from a county, I would encourage you, one, to reach out to them and set up a meeting. Two, if you would like some support and you think it would be helpful to have myself there or others, let me know, and we're happy to support with that conversation, because I think there's a lot of confusion even from child welfare in terms of how we're implementing plans of safe care, because we haven't created a distinct referral versus notification process. So it's creating confusion for both of our systems, and also some conflict that's resulting in us not serving our families in the most supportive way. But it is of a high priority to address by our state in like the next year.
Yeah, just quick follow-up question. Are hospitals legally required to do that when they receive one?
I can't answer that. I have unfortunately received, and I know that's frustrating. I would say speak to your legal team. I would say speak to each hospital, speak to your legal team. Because right now, where I am with our legal guidance, I've been asked not to provide any legal guidance to hospitals about their practice until we have our guidance clear. So I am frustrated by having to hold back as well, and I know that that's like not the most helpful answer. But I would say definitely talk to your legal teams. We are working on getting our guidance out to our counties in the next month. So it is it's a like rapidly changing area right now.
No, super appreciate that. So thank you for your work on it.
Shannon, Dr. Bruns, thank you. We appreciate your time and the dedication that you have for helping us all over the state make this better process. We will share out the slides in a follow-up email. If we don't have your email, please drop it in the chat. If you're not on our sort of newsletter or distribution list, we'll stay on here for just a minute so we can collect your emails, and we'll also share contact information. So if you have questions you'd like to ask offline, we'd be happy to field those for you. Otherwise, April, we have our cannabis education session. So please mark your calendars. It's going to be a great time. If you can't make it, it will be recorded, and we'll distribute it afterwards. So Thanks everyone for attending. Good to see you all.